So this session is on climate and health in Georgia, and first of all, my name is Paul Schramm. I'm the climate science team lead for the climate health program at CDC here in Atlanta. So I was really excited to see that health came up during the plenary session this morning because I didn't hear too much about health yesterday. And a lot of times when we're thinking about climate resiliency, climate adaptation, there's a lot of focus on infrastructure, on systems, on agriculture, on energy. But really human health is something that climate change can impact in a lot of ways, and that's already happening here in Georgia. We've already seen it with things like shifts in vector-borne disease, increasing number of extreme heat events, and a lot of different things across the state that are not only happening already but are projected to continue. So in this session, we're going to hear from 4 different speakers about their work on health effects from climate change here in Georgia. And I think it should be a really interesting session. We'll be covering a lot of different topics ranging from pollen to heat, and there really will be a focus on health equity and how climate is in fact affecting the health of the most vulnerable populations. So because you can read all of those bios online, I'm not going to read all of them, but I'll just introduce each speaker by their title. So our first speaker is Claudia Brown, who is a health scientist, and she works with me at Centers for Disease Control and Prevention. So, Claudia.
Hey everyone. So as Paul mentioned, I'm a health scientist with the CDC's Climate Health Program. Let's see. So in the CDC, we're thinking about health in a whole range of and host of issues. While today I'm going to be focused on some of our respiratory health focus around pollen, specifically in Atlanta and Georgia. You can see here that actually climate change has huge direct and indirect impacts on public health, ranging from changes in prevalence and severity of heat-related or high heat days, extreme weather events, respiratory health issues related to wildfires and pollen, and as well as ozone and those high smog days. And then changes in vector-borne diseases. So that's ticks and mosquitoes and the host of diseases that are associated with that. So here in Georgia, we're all very familiar with the pollen. I grew up in Calhoun, Georgia, went to Athens for undergrad, and live in Atlanta. I mean, we have a huge pollen season. In March, we all see that yellow film coat our cars. It's makes us feel a little groggy, not feel too good. And it has significant public health effects. So hay fever, which is caused by seasonal allergies, affects 30 to 60 million people. That's 15 to 20% of adults, and a disproportionate effect on children with up to 40%. Outdoor seasonal allergies also exacerbate pre-existing health conditions. If you have asthma or COPD, allergic rhinitis and seasonal allergies can really aggravate that. And then there's huge economic effects of this. So the annual medical costs related to pollen exceed $11 billion per year. And that's not including the indirect effects of lost school and work days. So this is what the pollen season looks like in Atlanta. We can thank our Atlanta Allergy and Asthma clinic up in Marietta for this data. Pollen data is actually very difficult to collect, very resource and time intensive. So we are lucky that here in Atlanta, we do have a National Allergy Bureau certified pollen counting station and there are only around 80 of those in the US. And this is one of the longest standing counting stations in the US with over 25 years of data. So we've been working closely with them and looking at the trends and the seasonality of this. So this is the average pollen season, though pollen seasons vary year to year pretty dramatically. You can see the red is tree pollen, the green is grass pollen, and the blue is weed. So we really have in the springtime a high tree pollen count starting around March. Then as we move into the summer, the grass pollen starts to peak, and then our weed pollen season peaks in the fall around September, October. So this graph is a little misleading because while we have really high pollen in the spring from trees, there are significant health impacts from the grass and weed pollen, even though they're much lower pollen levels. They're very allergenic. So then this is what the distribution looks like. In the spring, we have, as I mentioned, primarily tree, and that's split between oak and pine. Pine pollen is that really thick yellow pollen that you're seeing on your cars that, I don't know if you saw the videos last year of a tractor hitting a tree in Atlanta and all this pollen came out of it. That's the pine pollen. And while you see it, it's so large that our bodies actually don't absorb that as much as some of the pollens that we don't see that are much finer, such as the oak. Though they do peak at the same time. So when you see that thick yellow, you're actually experiencing the peak of the tree pollen season as well. And then the fall distribution is primarily ragweed. And that's very allergenic. You see that in areas where the land has not been kept up. It takes over when not mowed, and it really has a huge health impact. And then a little bit of elm tree pollen in the fall. So what are we seeing with climate change? Climate change, as we know, is extending our summers. They're shortening our winters, and that's having an effect on how the pollen season distributes in all places. And it's causing the pollen season to shift earlier. So it's starting earlier, and then it's also lasting longer. And we're also seeing with increases in CO2 that plants are more productive, which is creating more pollen. So we're actually seeing higher pollen counts. This chart on the right is showing a look at change in ragweed pollen season length across the US. You'll see as you move further north, we're seeing a higher increase in the pollen season for ragweed, though we're still seeing that increase in the south as well. And then that has health implications. We're seeing allergic rhinitis prevalence increase. A study found that from 10% of the population that suffered from allergic rhinitis in 1970 increased to 30% in 2000. And this is being seen globally. So at CDC, we did a literature review looking at 62 peer-reviewed studies and hundreds of pollen analyses and found that this is a similar trend all over the world. We're seeing an earlier start date, a later end date, and an earlier peak date, so the whole season's kind of shifting. And when we're looking at production, we're seeing increases all across the board, from total annual pollen to mean daily pollen to peak pollen, which is that highest pollen level that we see in the year. So now I'm going to kind of drill this down to what we're seeing in Atlanta. This is looking at temperature averages across the years that we have data, pollen data for. You'll see the top left is spring temperature minimums are increasing. the number of freeze days are decreasing. And then the summer maximum and minimum temperatures are increasing. And we're seeing that shift in the pollen season. So this is looking at the length of the tree pollen season in Atlanta, and that's a really significant increase from year to year in general trend. So similarly, we're seeing that increase in pollen production. So we have analysis that looked at the change in various months for different groups of pollen. And we're seeing that increase in specifically all pollen types, both all year round and in the spring and in the fall. And with that, we're seeing, which is important for health, but an increase in the number of high pollen days. So while the pollen season might be really long, the number of days where it's high, those are the days that, as someone who suffers from allergies, I'm most concerned about. And we're seeing an increase. That green is the spring tree season, seeing an increase in the number of high pollen days. The orange is the fall weed season, and we're additionally seeing a little bit more of an increase in that number of high pollen days. And so then, going back to kind of piecing this all together, we're seeing these trends in the pollen, and we know what our climate trends are, though actually conducting a correlation analysis, looking at how the temperature is directly impacted or connected with the pollen counts, that's the next step to say, what is the causation or association of the two. So this is showing the spring average temperatures and how that compares to the peak pollen day. So while it looks like a decrease, it's the day of year. So it's showing that the peak pollen day is becoming earlier as temperatures increase, which is what we're seeing. And then similarly, as temperatures increase, we're seeing a increase in the average pollen counts. So why is this important, and what can we do about it? Understanding, as I mentioned, Atlanta is one of the few pollen stations in the US. This information is really important. We have a huge knowledge gap around pollen and how it's occurring across the US and how climate is affecting it. This is important for not only people that suffer from allergies, but the physicians and allergists themselves that are treating these patients. Because as we have found, there are some treatments that require starting weeks ahead of time to prepare for the pollen season. So very important to know more and kind of gain more knowledge about what's going on with pollen in the U.S. Thank you.
Let's see if I can work the mobile mic. Okay, so we will have time at the end for general questions about climate and health, but we also have time now if anyone has specific questions about pollen in Atlanta for Claudia. And we'll be using the microphone because we are live streaming. Yeah.
Although you looked at the relationship between temperature and pollen, I'm wondering about how rainfall mediates the effect between the two as we move into droughts.
Right.
How will that impact
So
pollen?
yeah, that's a very good question, and that's something we've been looking at. It's actually more complicated with rainfall and how it affects plant production. So it's not clear because you could be looking at years ahead of time in the drought index, and that has a negative effect on the plant production, whereas the rainfall within the season also has big impact, and we're seeing so much variation. So we haven't found a great link between the two. I think it also varies from species to species, where weeds are much more affected by the rainfall versus trees and these kind of longer living plants.
Other questions? All right, well, as I said, we'll have more time at the end, but thank you again, Claudia. So our next speaker is Major David DeGroot, who's the director of the Heat Center at Fort Benning. Major?
Good morning, everybody. Thank you for the opportunity to talk to you today. I want to make sure I use the remote correctly here. So yeah, as introduced, I'm the director of the Heat Center at Fort Benning. This is actually a new initiative of the U.S. Army. It actually was created officially when I got there this summer. I've been a Georgia resident for, count it, all of 4 months. I just moved here from Hawaii, actually, so quite didn't change. But that's what the military does to you. But the military's interest in the health effects of environmental extremes, so talking a little more broadly, not just heat, but also cold and high altitude, dates back quite a way. I'm getting ahead of myself. Talk real briefly. So Fort Benning, one of three Army bases in Georgia. There's also Fort Stewart and Fort Benning. They have a much lower heat illness incidence than we do at Fort Benning by virtue of the population of soldiers they have there and what they do. Fort Gordon is primarily signals and cyber, and it's not a training base. Fort Stewart there is an infantry division there, but those are soldiers who have been in the Army for, as I sometimes joke around Fort Benning, more than a day. Fort Benning is a major basic training installation. Half of all U.S. Army soldiers do their initial entry training at Fort Benning, where they may be coming from other climates where they're not acclimatized to the heat. Their physical fitness is not as high as a soldier who's been in for a while, and we know that physical fitness is protective against heat illness. Here's my historical perspectives piece. There's an organization called the Harvard Fatigue Laboratory. It was actually in the Harvard Business School of all places. This went from 1927 to 1947. A lot of its funding came from what was then called the Department of War. The Department of Defense funded a lot of the work there, and they looked at the effects of environmental extremes on warfighter health and performance. A well-known environmental physiologist named Edward Adolph, under contract for the U.S. Army in 1947, published the book Physiology of Man in the Desert. How does man cope with extreme heat, dehydration? Some of our early knowledge of the negative effects of dehydration on physical fitness and performance was from Adolph's work. The Army itself had its own laboratories dating back to the World War II era. Climate's right up there in the title of one of them, the Climatic Research Laboratory in Lawrence, Massachusetts, and another place called the Armored Medical Research Lab that was at Fort Knox, Kentucky. And actually those two units merged into the Army Research Institute of Environmental Medicine. And actually that's actually where my career started 22 years ago. Still in operation. They do great basic and applied science there, but what they don't have the ability to do is study actual heat casualties. If we don't do anything clinically oriented on someone who has become a heat casualty, you can't ethically, the IRBs don't let you do that sort of thing, right? we can't induce heat casualties. So they've been limited in what they can do. So that's part of why we have the Heat Center at Fort Benning. A tool that's used throughout, not just in the military, but in athletics, and the NCAA based their guidelines, is the Wet Bulb Globe Temperature Index. This has its roots. It was created by a pair of docs at Marine Corps Recruit Depot, Paris Island they started their work in 1953. The work was published in 57, but it was just simply stratifying risk based on temperature and implementing mandatory work-rest ratios to reduce the incidence. And let's see if I can come over this so I can talk to this slide a little bit. I know you can't read the figure to the right, but if you look in that bottommost curve, the one that to the far right is the lowest, the y-axis is incidence. That's the incidence rate after they implemented their controls of when the WBGT, the military's version of a heat index, exceeds a certain temperature, mandatory reductions in, or changes in the work-rest ratio, so more rest time, less work time in the heat. And this is still used today. Our guiding document for heat stress is a document, Technical Bulletin Medical 507, Heat Stress and Heat Casualty Management. That's the highest level doctrinal document in the Army for reducing heat casualties. And we still use the WBGT as our guiding document. This is some current data for across the Army. I highlight in that red box at the top right, when you look at every installation, not just in the Army, but in the Department of Defense, just in frequency. So we're not talking incidents, that's a different variable. Just frequency, Fort Benning has the dubious distinction. We're at the top, year in and year out, for the number of heat casualties we have. By virtue of, it's the training we do there. The figure on the left, if you just look at just the trend line, which way it's going, it's increasing. That's our incidence of both heat exhaustion and heat stroke over the last 5 years. So the problem certainly isn't going away. And Fort Benning is getting bigger. They've just almost doubled basic training from 14 to 22 weeks if you're infantry. Well, that's their basic training and their advanced individual training. So at any one time, our population is going to increase about 50%. This is some work I did a couple of years ago when I was at the Army Public Health Center, just looking at the weeks of the year and the distribution of our heat casualties across the year. And this is particularly for Fort Benning. You'll see that year-round heat illness is a risk there. Obviously, it peaks in the summer months. It doesn't take a big stretch of the imagination to think what these curves are going to look like. So the red curve is the dry bulb temperature. The green is the blue is the wet bulb temperature. And then the vertical bars is the incidence of heat casualties that as it, they mirror each other. It gets warmer, the incidence goes up. Well, imagine with climate change, just shifting that whole curve upward at every point, the number of heat casualties we're going to see is going to increase. Part of our and this can be quite serious. My friend and colleague Robert Carter a couple years ago published a retrospective study. Over a 22-year period, we had 37 deaths attributable to heat in the military. Just at Fort Benning, over a 20-year period, we've had 8 deaths due to either heat stroke or hyponatremia, water intoxication, which is often coincident with heat. And what happens is we get into this cycle that we've called it the tragedy loop, that you have one of these tragic deaths. Trainee dies. The last one we had was 2016. Oh crap, we have to do better. And we do. There's more attention paid to prevention measures, to getting out there and educating the drill sergeants and the small unit leaders to recognize someone who's suffering some adverse effects from heat before it gets really bad. Training, and you do good. But so there's a period of sustained performance, but it's the military. People move every 2 or 3 years. In 3 years, you've had 100% turnover in some units. There's no such thing as institutional memory in some organizations. So then it happens again. So we're trying to break that loop. Now, that's part of what we're trying to do with the heat center. Oops, I'm hitting the wrong button. That's why it's not advancing. So, like I said, it was just established this year. Right now, it's myself and a couple of contractors and a bunch of the staff from the hospital, but there's only 3 of us that our only job is the heat center. The rest of the supporting people are clinicians who have other primary jobs. And I say it started in 2017 because that was the last death we had there was 2016, and some of the clinicians who were still there were the clinicians who treated this casualty when they showed up in the emergency department at Martin Army Community Hospital. So for some people, it's personal, trying to break this cycle. We're actually working in conjunction with the Uniformed Services University of the Health Sciences. If you've never heard of that, it's co-located with Walter Reed National Military Medical Center in DC. It's the Department of Defense has its own medical school. If you didn't know that, that's the Uniformed Services University. It's the DoD's medical school. Within that, there's an organization, the Consortium for Health and Military Performance. So we're closely aligned with them because what we're doing is a DoD, we want to benefit the whole DoD. Yes, my focus most of the time is Fort Benning. What can we do getting out there, working with unit leaders and whatnot to minimize the incidence of heat casualties, which are going to happen, but also to spread lessons learned and to serve as a resource across the DoD, because while we lead the DoD in frequency, overall, we're still only about 15% across the entire DoD. The Marine Corps has the same problem with Quantico and Parris Island. The Air Force does all their enlisted basic training in San Antonio, Texas. They have a heat stress problem down there. The Navy does too, and they do their basic training in Great Lakes in Illinois, but nonetheless, they still have heat problems. So really what we're doing is 3 lines of effort. One is prevention. I get out there and brief full colonel brigade commanders who are just coming into command there. Hey, this is what you have to cope with. This is the historical challenges you're going to have as a leader when it comes to heat illness in your formations, right down to drill sergeant's level of a room full like this, an audience like this, of drill sergeants, the instructors who are out there every day working with the trainees. What do they need to know? The medical management, what can we do to improve the clinical care? One of the things we've done there is all of the ambulances on base, because we've got our own on-base EMS, have a device called an iStat. This is where we can get their serum sodium levels and make that distinction between a hyponatremia and a heat stroke, because symptomatology-wise, they can look very similar. So we need to make early determination. They have chilled saline on the vehicles. They can do cooling and route care. So we've pushed the patient care beyond the walls of the hospital to the ambulances, sharing those protocols with other installations. And then research, leveraging that volume of casualties. I mentioned earlier Usarium and their great work in basic applied science and heat stress, but they can't work with casualties. Well, we have a lot of casualties there. Let's see what we can do to understand return to duty. If I've suffered a severe heat stroke, when is it safe for me to go back to my unit with unrestricted duty and do my job, whatever that job is for the Army, in a way that's not going to pose additional risk to my health because I haven't fully recovered? If my liver or kidneys are still damaged from the heat stress, if I'm still suffering the effects of rhabdomyolysis, there's a lot we don't know about the return to duty. And then the balance of that coin is we don't want to keep them on restricted duty for too long because that impacts unit readiness. So there's a balance to that. So those are really the big picture strategic goals of what we're trying to do at Fort Benning. So thank you for your time and attention. Appreciate it.
All right. Thanks. Oh, you're good. Thanks, Major DeGroot. Questions?
That was a great presentation. I have a few family members that are in the Army and also retired Air Force. So my question to you is, after seeing these deaths attributed to heat stress, is the Army, because it's hard to reinforce change if the culture isn't accepting it, so has the Army or the military in general been trying to change the culture at like these training facilities?
Yeah, that's a great question, and I get what you're getting at. And it is something we do address, because when I talk with unit leaders, one of the risk factors we identify is someone who's highly motivated, and that kind of speaks to the culture a little bit. If I'm hypothetically, I'm an infantryman at Fort Drum, New York, which is north of Syracuse. Their summer is not the same as South Georgia. And I've been waiting for months to get a slot to go to Ranger School, and my Ranger School date is now in July. That person is highly motivated to excel, to not fail that course he's waited to get into for a long time. That alone makes it a risk factor. That's some cultural thing, and to not be afraid to, it's not admitting weakness. It's the same thing, the same cultural shift we've been trying to push with seeking out assistance for mental health and PTSD and stuff, that destigmatizing those sorts of things, that it shouldn't be viewed as a sign of weakness when you're doing the right thing, you're being smart and slowing down, you're stepping out of a formation because you're at risk. So that is something we do address. Culturally, big army, I don't know how we can affect that.
I mean, I know it varies from to each base.
Yeah.
And just kind of following up with that question, I know you said that you are implementing them into the education and the training. Have the people who are teaching it, have they been buying into it? Because it's really hard to make change if the people that are selling it don't really buy into it, if that makes sense.
No, it absolutely makes perfect sense, and I think we do have good buy-in. One thing about what we're doing, so on one of my earlier slides, I said, when I talked about the number of cases, especially with the deaths, these are preventable.
Right.
Every death is preventable. Heat exhaustion, which is relatively mild, I could have a heat exhaustion today and return to duty tomorrow. It's a cardiovascular sufficiency. There's no damage. That's inevitable. We're doing military training in the summer in South Georgia. It's going to happen. It's the heat strokes and the deaths, and the severe heat strokes, the kid who's hospitalized for a week, that we want to address. So when I do talk to guys, I ask them questions. Like, one, we have a misconception with hydration and the importance of that as a risk factor. And it's a really two-part question. How many of you think that you can be normally hydrated and still become a heat casualty? I just show of hands, because you can, yes. How many of you believe that you can be dehydrated? I'm talking 2 or 3% body weight loss due to dehydration and not become a heat casualty. Because you can be hit. It's not a good correlation, that breaking those molds, because one of the problems we have, we mentioned hyponatremia, water intoxication, is a behavioral problem. It's not a medical problem, it's behavioral. This is people purposefully over drinking in an effort, because I go into the PX on base, and you go into the section where you can buy the reusable water bottles, and it has written on the sides, hydrate or die. God, it's terrible messaging, drives us nuts. This year, we've had 15 kids hospitalized due to hyponatremia, one with a minor brain bleed because of cerebral edema. And this is a behavioral problem, because he thought he was protecting himself by ignoring his body's signals to say, stop drinking. And keeps drinking. So that is definitely, we're getting there.
Yeah, and additionally, electrolytes aren't being being generated because so much water, you're drowning yourself. So,
Yep.
So that's all my questions.
All right.
Thanks. Thank you.
Yep.
Other questions? Nope. All right.
Great.
Thank you. So our next speaker is Guanyu Huang, an assistant professor of environmental and health sciences at Spelman College. So we'll hear a little bit about the research that's happening locally at a university. Guanyu.
Good morning. My name is Guanyu Huang, assistant professor of Spelman College. All right, here we go. So I'm going to talk about the high temperature and preterm birth rate at Atlanta. And this research is actually based on my student thesis. And she actually graduated in May. And she's now a student of Auburn University. As a person graduated from University of Alabama, it's really kind of hard for me to send my first student at Spelman to Auburn. And also I would like to thank my student, Alex Brooks. She's right over there. She did a great job to this research, and also my colleague at Department of Mathematics at Spelman College. Okay, so as we know that Atlanta is the 10th largest metropolitan area in the United States, and there we have many new babies, and the north side hospital is called their baby factory because we have many newborn babies in north side hospital. And over the last few years, Atlanta is getting hotter and hotter. So I'm pretty sure everybody knows about that. And here is a question that coming to our mind that says, how their high temperature may harm their women's health, especially for the pregnant women's health. And would this effects be the same for the women with different races? So the goal of this study is to understand how those high temperature would influence the preterm birth rate in Atlanta. Okay, so we've been talking a lot about climate, temperature. So I'm going to show you what's really going on with the temperature in Atlanta. Those data are actually from the NOAA local station in Atlanta areas. So the red is the daily maximum data. The green is the daily minimum temperature, and the black is the daily mean data. So as we do these, this is actually from 2007 to 2017. As you can see, Atlanta is getting really hot, and you can see here all those temperatures actually getting higher at 0.1 degrees Celsius a year. So if you combine them together in 10 years, averagely the temperature in Atlanta is actually increased 1 point-ish temperature over the last 10 years. So we also talk about the extreme temperature get more extreme. So I'm pretty sure many of you remember what happened at the January of 2014. We got a little bit of ice and snow in Atlanta, and the city was kind of closed. Yeah, and at that time I was at Cambridge, so I was like, there was not really ice. So yeah. Okay. At the same moment, air pollution and air quality also are critical for their people's health. This is actually the daily mean 8-hour average ozone values in Atlanta. Fortunately, Atlanta's ozone is actually getting lower over the last 10 years, 0.3-ish ppb per year, which means in the ozone, we're getting less ozone in Atlanta. And the EPA standard for ozone is actually 17, so we're good. We're good with ozone here, based on this number. Okay, particle matters, or those PM 2.5 and PM 10, which is basically the different size of the particle matters. So as you can see here, this is the EPA 24 PM 2.5 standard, and PM 10, PM 2.5 are getting lower and lower in Atlanta. So we are pretty happy about those data, those results. Okay, let's take a look at the carbon monoxide and the NO2. For CO in Atlanta, it's pretty stable over the last 10 years, a little bit, but I don't think it's a critical increase. But unfortunately, NO2 is actually increasing in the last 10 years. This especially, we noticed that the trend before 2014, it was actually decreasing, and all of a sudden it's actually started to increasing in Atlanta. We think it's a very interesting, phenomenon. So we're gonna get more studies on that. It may be related to more people moving to Atlanta, those vehicles and cars, those emissions caused by the traffic. But we definitely need to study more on that. So let's take a look at what's really going on the climate and air quality in Atlanta. Temperature, definitely, Atlanta is getting hotter and hotter, for sure. And air quality generally is getting much better than before. Unfortunately, especially the PM values and ozone are actually decreasing. For some reason, NO2 is increasing. Let's need more attention on that. So let's take a look at the birth number, since we're just studying the high temperature and preterm birth rate. So we're focused on from May to September during 2017. As you know, that the summer in Atlanta is actually a lot longer than other places. So we define the Atlanta city areas as the Fulton and the DeKalb counties. So here is the number, birth numbers, give you the general ideas that how many babies that we have in the last 10 years during summertime in Georgia and Atlanta. So you basically see those ratios, the different race structures in Atlanta and Georgia. Okay, so we studied the preterm birth rate as actually defined based on the CDC and the WHO is actually if their age is less than 37 weeks, we define it as their preterm birth. So as you can see that those preterm birth rate is definitely different to different races, and unfortunately, black women has much higher preterm birth rate than any other races. And it's easy to understand that Atlanta has a better preterm birth rate than the entire Georgia state. So then we actually do some regression study to see how the temperature is actually related to the preterm birth risk based on all the people and people of different races. Unfortunately, for the black people, they have the highest preterm birth risk at the same moment. It looks like as the temperature goes up, the preterm birth risk is actually goes up a little bit. And for the white people, it goes up a little bit as well, but not as big as the black people. So it is very interesting to see those Hispanic people and Asian people, as the temperature goes up, their risk actually goes down. So since it's very new research, we just did that. So we definitely need more further studies on why and how this could happen. Could be something wrong with their models or whatever. But this is true that the preterm birth rates are definitely different for the people of different races. So here's a little summary. Besides the air quality and the climate, we just talk about the relationship between the preterm birth rate and temperatures is actually varied to different races. And the preterm birth rate is controlled by many factors. We definitely would to do more research on that. And we thanks all the data provided by the Georgia Department of Public Health, US EPA, and NOAA, and my student is supported by 2 NSF programs. Thank you so very much. And I would like to answer your questions.
All right, thank you, Dr. Huang. Questions? Eager question over here.
Thank you. I appreciate your last bullet about more work needed because it seems like there's a lot of other variables to control for in the model, like access to care, structural barriers that people have, problems with adequate prenatal care, and other behavioral factors and things like that could explain some of the trends in time.
Yeah, thank you so much for the comments. We definitely have those data, and we're actually working on those to make our model, accounting all those variables in this study. Thank you.
Hey, I'm not particularly knowledgeable over the different things that you could have measured for in the air. Why did you pick the particular, like particulates, carbon monoxide and not carbon dioxide?
Thank you for the question. Those are actually the EPA standard air pollutants that are actually by the law of Air Clean Act. So they're like the standard air pollutants that we believe has the most impacts for the people's health and in the field of air quality studies.
Hi, that was a great presentation.
Thank you.
Did you tease apart degree of prematurity at all? So less than 37-weeker outcomes are very different from like the early preterm birth outcomes, and I wonder if you saw any difference or layering out effect there.
We are still working on that. That's a great question and great comments. We definitely will, consider that in our research.
Other questions? All right, thank you.
Thank you so much.
So our last speaker is Arie Manangan, who's a health scientist and a health geographer in the Climate and Health Program at CDC. Arie?
All right, good morning, everyone. Can you hear me? All right, so I'm just going to click this button to advance through the slides. Okay, the green? All right. Okay, so today I'm going to be talking about flooding risk to medical infrastructure. So what we're doing is a national assessment of flooding risk to medical infrastructure, and what I mean by that are your hospitals, your nursing homes, or even your dialysis clinics. So what we did was we first compiled a comprehensive flood data set, combining data from FEMA, the National Flood Hazard Layer, And using the EPA data where there are data gaps, we then determine which facilities are within a flood hazard area, and then we assess the capacity of these hospitals at risk of flooding. So when I talk about flooding risk, a lot of folks are familiar with the 100-year floodplain. So this is just kind of describes to you what the 100-year floodplain is. Here you have your stream channel, that's that dark blue water area. And the 100-year floodplain are the fringes of that, the floodway and the fringe. So a 100-year floodplain actually means there's a 1% chance of flooding risk in any given year. So a 500-year floodplain is a 0.2% chance of flooding in any given year. So this is data from the National Climate Assessment. I should actually update this to the latest climate assessment, but there have been increases in both total precipitation and extreme precipitation in the United States, and this may be contributing to the increasing floods. So flooding risk to medical infrastructure has been detailed before. Here we have a HHS report on healthcare resilience under climate change, but also New York City, a very progressive city, has actually conducted an analysis of looking at those hospitals within a 100-year and 500-year floodplain. So what we've done is build upon this analysis at the national scale. Here I'm kind of detailing the data that we used. As I mentioned, it's from FEMA. It's the National Flood Hazard Data Set. It's a compilation of effective flood insurance rates. However, it is partial coverage, and it only covers about 85.8% of the population. Here's another map of this. So those areas in white are those areas we actually don't have data for. I'm not sure if it pops up, but you can see in the coastal areas of South Carolina, we actually don't have NFHL data. And in the latest analysis, what we're doing is using an EPA model data set to fill in those gaps. And here is our American Hospital Association data. I'm sure you can really see this slide. Something happened with the formatting. So what actually the American Hospital Association data set is a survey. So those are all the hospitals in gray there. And that actually gives us the hospital capacity, and when I say that, how many beds and the services provided by hospitals. Oh, wow, okay, so the flooding risk to medical infrastructure in hospitals, so these are actually our results. Hopefully you can see this as well. So you see the red dots and the orange dots. So after detailing or processing all the floodplain data, very high resolution topographic map scale data for the entire country, we overlaid that with all our hospital data. Those hospitals in red are within a flood hazard area. Those hospitals in orange are also in a flood hazard area in the 500-year floodplain. Wow, that's too bad. Okay, so so here are our results. So I can kind of tell you these results. So actually what has happened here is that we have 8.8% of all hospitals in the United States are within a flood hazard area. And we actually have 8.8% of all hospital beds are within a flood hazard area. So again, this is a Georgia Climate Conference. So we've actually done this analysis focused on the Georgia area. So this actually incorporates that latest data set that I've talked about from the EPA. So that has that modeled flood data, but it also provides those gaps. So we're seeing, again, those areas in red, those hospitals in red are within the 100-year floodplain. Those hospitals in orange are within the 500-year floodplain. And those areas here, this is around the Savannah, Georgia, and the coastal areas of Georgia. So you can kind of see the detail of the floodplain data that we're actually dealing with. So to process all of that is actually pretty computationally intensive, but we were able to do that. All right, a little better map here that works. So what we did was we took all those hospitals within a flood hazard area. We overlaid that with a future extreme precipitation in 2030. So you can kind of see those hospitals that may experience increased risk to flooding. Oh, bummer. So adaptation strategies. So one of the adaptation strategies we can do is the relocation of critical infrastructure. I mean, that makes sense. Also the site modification, which would actually be dam wall building to prevent flooding, such as here. You see this picture from Lourdes Hospital, that's in New York. Also, backup power generation during FEMA and some other hurricanes. Actually, backup power was being placed in low-lying areas like the basement. So that's probably not a good idea to do that. But also, there's also developing evacuation plans or training your staff in how to deal with flooding events. So in conclusion, I'm glad we could see this, but so we have approximately 450 U.S. hospitals, or 9%, located with a flood hazard area. So there are also regional differences that are observed in projected extreme precipitation. And we're seeing an increased risk for future flooding in anticipated areas where the risk of flooding was low. And this leads us to that hospitals may experience more frequent flooding in the future, and we may need to implement adaptation strategies to become more resilient to the effects of this flooding. That's all I have, but I wanted to show one more slide if we have time. So this kind of deals with the whole vulnerability to climate-related health effects. So what we really talked about are hospitals that are insufficient, so those hospitals with the flood hazard layer. So the Climate Health Program has also developed some guidance on how to develop vulnerability assessments. So actually, this is a heat vulnerability map. What it does is it takes into account these 6 different data layers. We factor them accordingly, and we have some guidance on how to do that on our webpage. But what this does is takes all these different factors like poverty, social justice type of issues or layers. We also take into account, as I mentioned, hospital insufficiency. So maybe we could replace this hospital insufficiency data set that you see here with the one that we just developed for those hospitals within the flood hazard area. On the top right here, you have heat extreme event exposure. We could replace that with the number of flooding events that a county has experienced. And on the bottom right, you see a % impervious surfaces. So we could replace that with a % flood hazard area per county. So what we do, we'd overlay that and end up creating a vulnerability map. It would be a flood vulnerability to the climate-related health effects. Okay, I think that's it. I apologize for those slides there, but.
All right, thanks, Arie. Any questions for Arie?
Hey, thank you. You had a red couple of dots west of Atlanta, and I wasn't sure where they were, and since it's a Georgia conference, I thought we need to know that.
The west of Atlanta, actually, I do have those. Those are in Rome, Georgia, I believe, and then there's a place called Cedartown, if I remember, Cedartown, Georgia. So those were, I just looked at those this morning, so I knew you'd ask that question.
Well, they're streaming, so.
There's millions of people, so.
Now my voice is gonna crack, I'm nervous. Well, that was excellent, thank you. I'm curious as to what, in addition to the studies, CDC might be doing. Is there outreach to, I forget, AHA?
Yes,
Is there
right,
outreach
right.
to hospitals? Is there training? Some of the strategies you suggested are certainly kind of infrastructure, but some of them might be operational, programmatic. So what else is CDC's program, if there is one, kind of around this encompassing?
Yes, sure. I mean, that's a great question. So this is kind of a conversation starter piece with those hospitals, like the American Hospital Association. So we've actually presented this to them. They were very interested, and from those we were able to talk to healthcare systems like the Cleveland Clinic. So we've actually provided them this information. Hopefully we'll have some workshops in the future. Just try to figure out the best ways to deal with flooding events and how you can prevent this from happening. You can help those folks that are being serviced by these hospitals. But yes, this is, again, just a conversation starter. It's a national assessment. So, we are not really, with such a national assessment, how accurate are these? So with being in Georgia, I believe someone someone said, hey, I didn't actually realize there was a hospital in Savannah in a flood hazard area. It's like, well, yeah, I think there is. And then so I went last night, I double checked my data, I put it over, a Google imagery, and actually it is in a flood hazard area. So that's the kind of quality checking that we need. So we need buy-in from hospital organizations to figure out what we need to do. And we talked about the adaptations that we need to do. But again, this is just a conversation starter, but hopefully some workshops in the future.
I don't have a question, but just a comment. I participated in the response to Hurricane Katrina in New Orleans. And I remember seeing on the TV people walking in knee-deep water by the Superdome. And in my work, I came to realize that the Tulane Medical Center, the LSU Hospital, and the VA Medical Center were all right next to each other, a few blocks from the Superdome. And all three of them had their emergency generators in the basement.
Yes.
And this is below sea level.
Right, very surprising.
You may want to also touch base with architects that design hospitals.
No, I totally agree. Thank you for that comment. Yeah, actually, after reading that, I couldn't believe it. You're right, yeah.
Hi, this is more of a general question for everybody. Is that okay? So I'm just thinking about how research and the timeline from translation of research to actually getting into the clinical setting. We've said it's something like 17 years. And with the rapidity of change, with climate change affecting various areas, I'm just wondering what are the considerations from CDC or people like the Heat Center at Fort Benning where there's actionable information coming out that can help local communities, outdoor workers, pregnant women right now, given that things are going to change so rapidly that the research that's done may, not keep up with how rapidly things are changing. So some considerations about how to disseminate information given this new clinical setting as well.
Would you have a better answer for this?
All right, then. Yeah, let's
yeah,
go. We'll
let's
go ahead.
do that.
That's a good
Just
segue.
because
open
that's
up to the whole.
maybe something not that I can answer. So.
Minutes, but
It's a great question.
sure, you can. However you want to do it.
Yeah. So I can address that a little bit from the Army's perspective to get information out. So big Army structure-wise, Training and Doctrine Command owns every Army school. It goes from basic training all the way up to the War College that senior colonels go to. They have a heat illness prevention committee. Meets every month. I'm a member of it. There's our venue, and it's actually growing to not just be an Army organization, but we usually have people calling in from Marine Corps Recruit Depot, Paris Island, from the Air Force in San Antonio and other places. So we do have some mechanisms to share knowledge that we can get stuff out sooner. We do have ways to improve. I mentioned our technical bulletin 507. The revision of that is currently in the approval process. It was last revised in 2002. So, yeah, what was it, 17 years? There we go. 17 years between editions. We've learned a lot since then. But we do have opportunities through different working groups and networking to get information out there. And that's actually one of the things we're trying to do better at Fort Benning is as we develop this knowledge of local best practices to share that with other installations that are facing similar challenges. So.
I think this might be a good opportunity to plug the BRACE program at CDC. So the CDC Climate Health Program actually funds 18 grantees, 16 states, and 2 cities to implement the Building Resilience Against Climate Effects framework. And in that framework, it is training and providing state and local public health departments, who are the ones that are responding and taking the action here on climate change, with the tools and the resources and data and network to equip them to not only learn about what's going on for them locally, but learn best practices and how to adapt.
Yeah, and I would add, you mentioned this really long lag between research to practice. One thing that we've been doing and that we've seen health departments do is to shorten that lag by having their research inform systems that are already in place. So a good example of that is health departments working with the National Weather Service. So the National Weather Service already has heat alerts, but they don't necessarily incorporate health data. And some of our grantees, for example, the state of New York and the New England Heat Collaborative, have used their local health data and had their epidemiologists look at what temperature are we actually seeing health effects, and then talk to their local weather forecasting office and actually got the policies changed so that the threshold at which heat warnings are put into place are lower than they used to be. So that's something that can be done on a shorter time frame. So, yep. Actually, you've both asked a question already.
Okay, I'll let you have it later, Becca. I just wanted to make one comment about the Nurses Climate Challenge. So I'm on the nursing faculty at the School of Nursing, and the Nurses Climate Challenge is a national effort to try to get nurses on board. And as you all know, nurses are the largest health profession in the United States, and they actually, according to Gallup poll, are the most trusted profession. So I think we need to work with the nurses who are in the hospitals, who are seeing these kinds of generators in the basement, thinking about how they can prepare for climate change. So there's a national action I'm participating on in a focus group where we're actually asking different universities like Emory University to climb on board to this challenge and really work on, I think a lot of nurses maybe don't pay attention to the issue, and this is a goal around educating them to think proactively. So I just want to put a plug in for the Nurses Climate Challenge. And now Becca.
Thank you. I'm a pediatrician here in Atlanta, and I was wondering if there's anything that we have similar to the BRACE program for accelerating integration of what we already know about climate and health effects into the clinical practice of medicine. We're still seeing this kind of gap between what we know from the public health side and how doctors out there on the front lines in the communities can respond. So is there anything that exists? And then what would you guys tell doctors? How can we be better partners in this effort?
Well, I'm not a physician, but we do have a program. I believe it's the University of Iowa. So we have some doctors that are developing some curriculum for med schools as well. I'm not sure how. Maybe you definitely have a better answer about how you can engage others in that.
I'm not sure if it's a better. I could give an answer. So my colleague at Uniformed Services University, DoD Medical School, we're working with Training and Doctrine Command to get into the curriculum for drill sergeants. So the U.S. Army Drill Sergeant School. You go to school to learn how to be a drill sergeant. You get selected for drill sergeant duty. You first go to Fort Jackson, South Carolina for 8 or 10 weeks or whatever it is. We're working with them to put into the curriculum how to educate on prevention of heat illness casualties. And in reality, drill sergeants, those are our first responders. Before EMS, those are the first responders, because what do we know about exertional heat stroke? Rapid aggressive cooling saves lives. You have to recognize that casualty up front and know how to implement what rapid aggressive cooling strategies you have available to you. So we're working to get that into their curriculum. That same colleague of mine at Uniformed Services University, he's in the Department of Military and Emergency Medicine. It's part of their curriculum up there too, so that any DoD trained physician has gotten some exposure to treating heat casualties. It's not going to replace the first-hand experience you'd have working at Martin Army Community Hospital, Fort Benning, Georgia, and the 500 casualties we see a year, but it's increasing their exposure, at least their awareness. I shouldn't use exposure in that context. Their awareness. So hopefully.
I can talk about how we actually educate our future health professional, doctors, nurses at Spelman College about their climate change. Since our department is actually environmental and health sciences, so half of our students are actually in the major of health sciences. Most of them will go to medical school, dental school, and nursing school, public health schools. So most of them actually take health science and their environment science related, for example, the atmospheric science, global environment change classes. So while they are in the college, they know what's really going on in the world, how we actually should do to protect ourselves, to protect our Earth from the global warming. So this is basically at Spelman what we're doing to educate our future health professionals about climate change. Thank you.
Thank you. We'll definitely appreciate any curriculum materials that you guys have been sitting next to me, and Emmeline Laney, another student at Emory, have almost single-handedly pushed forward a curriculum on integrating climate change in the first 2 years of med school at Emory, which is a brand new thing that's just been approved. So we're looking for more materials and would welcome anything that you guys already have, and maybe we can find a way to facilitate sharing among the med schools in the U.S. on these topics.
Thanks. And I would add, for any other medical practitioners in the audience, there are a number of nonprofits that have materials on climate and health. For example, the Alliance of Nurses for Healthy Environments, Physicians for Social Responsibility. There's a consortium, medical consortium on climate and health, and a lot of them have produced documents and curricula to help people. Yeah.
On the Medical Society Consortium for Climate and Health, there's not a Georgia chapter, but we're trying to start one. So if anyone's interested, let me know.
Thanks. We'll go here and then.
Hey, thank you. I'm Henry Slack. I retired from US EPA, where I dealt with, among other things, indoor air and disasters. And so one of the great things which challenges us in a disaster is the loss of power. In New Orleans with Katrina, they ran out of fuel in 3 days, and then so talk about how medical facilities can plan for these sorts of things, or if possibly they should be greening their buildings and bringing in solar panels and batteries to even prevent, if you're on oxygen, a 5-minute outage is not a good thing. Thank you.
Yeah, that's a very difficult question. So I guess what you can really do is just have a better plan on how to do that. There's no real good answer. I'm not sure if solar energy is able to power a hospital for 3 days after your fuel goes out. But it's just a matter of planning on how to do that, and just also, again, starting the conversation about the infrastructure that we need to build. And I guess that's really the answer, and the technology that we need to develop.
Thanks. I think one more quick question before we have to open this room up for the plenary. Yep.
Not quite a question. I'm Joan Kowal with Emory, and I handle resiliency and utility strategies. So to follow up on that, for those that heard Commissioner Eccles this morning, he was referring to the microgrid that we had proposed during Georgia Power's integrative resource plan, on that premise of really having more local resilience strategies for those events. And we had brought in folks from Princeton University who helped share their story on how they managed through their hurricane by having local generation, which includes, solar, battery storage. It's probably going to include natural gas as well. So, yeah.
Yeah, that kind of information, that would be great for other hospitals to know as well. So maybe in a future workshop, maybe we could address those issues.
All right, well, this session just kind of scratched the surface on some of the health effects that are happening from climate change in Georgia, but I know there's a lot of great work happening at universities, nonprofits, the government across the state. So let's thank our panelists once again.